Thank you. Thank you. So we'll go on with the talk. So the outline today, this talk has been geared specifically towards DM residents. So today we have a concept-based approach. We will start off by looking at what is blood pressure. We look at physiological regulation of blood pressure. We look at what are the factors contributing to hypertension, and what are the derailments caused by hormonal variations that can lead to hypertension. So when we talk about hypertension, it is a significant health burden, very similar to diabetes, which we are all familiar with. Sometimes we tend to not give hypertension its due respect that it needs. So a 20 millimeter increase in systolic blood pressure and a 10 millimeter increase in diastolic blood pressure is all that is required to double the mortality rate, particularly from atherosclerotic diseases like ischemic heart disease and strokes. And if you look at overweight and obesity, this accounts for a huge percentage of the risk for developing primary hypertension. So overweight and obesity are two exceptionally high risk factors for someone to develop hypertension during their lifetime. So when we look at blood pressure, this is a parameter that is maintained tightly across the entire mammalian kingdom. And what is the function of maintaining a blood pressure? So the function of blood pressure is essentially to force an adequate amount of blood supply throughout the vascular system so that tissue perfusion is maintained. And this is the most important and the primary function of maintaining appropriate blood pressure. And when we look at determinants of blood pressure, if we break it down to the bare minimum units, then there are these two parameters which essentially maintain your blood pressure. So the formula is mean arterial pressure is basically dependent on cardiac output into total peripheral resistance. So if you need to have adequate cardiac output and there is total peripheral resistance, so that is a resistance offered by the vascular tree. And these two parameters together help in maintaining your blood pressure. So generally, they kind of are related inversely to each other. So if you have a condition which increases your cardiac output, generally the total peripheral resistance will come down so that the MAP is maintained. So your body's regulatory mechanisms are geared towards maintaining a constant mean arterial pressure. So that's what you will see in this picture. You can see the green line, which is basically the arterial pressure, the mean arterial pressure. And irrespective of the disease state, you can see that the green line is maintained in the normal range. However, the cardiac output is what is shown in the red dotted lines. So you can see diseases which have increased cardiac output. For example, beriberi, AV shunts, hyperthyroidism, pulmonary disease, anemia, etc. You can see that in all of them, if you look at the total peripheral resistance, which is basically the x-axis, you can see that the total peripheral resistance is reduced in order to maintain the mean arterial pressure in conditions where cardiac output is elevated. In conditions where the total peripheral resistance or the vascular resistance is high, for example, if you have hypothyroidism or if someone has lost all 4 limbs, there is an increase in the total peripheral resistance. So in these conditions, you can see that the cardiac output diminishes in order to maintain a mean arterial pressure in the normal range. So this is technically how the body will adapt to maintain a normal blood pressure. So you look at the physiology of BP regulation in brief. So there are multi-level responses, of course, because blood pressure is such an important function. The immediate response actually occurs within seconds. So predominantly, it's a neural control system. So there are 3 mechanisms by which immediate response via neural control systems occur. Number 1 is the arterial baroreceptors. So you have arterial baroreceptors, which basically detect changes in blood pressure by the amount of stretch. And then it sends autonomic signals back to the heart and blood vessels to either increase or decrease the cardiac output or to make whatever necessary changes that has to be done. The second level is chemoreceptors. So these receptors will detect changes in the oxygen and carbon dioxide levels in the blood. Again, that will induce autonomic feedback responses. So oxygen levels will fall if tissue perfusion is inadequate. So that is how it will give a autonomic feedback response to appropriately correct the change that has occurred. And lastly, you have the CNS, which is basically the ischemia of the vasomotor centers in the medulla. If that happens within a few seconds, there will be an entire response, particularly if the blood pressure is falling, in order to revive the BP and maintain it and bring it back to the normal range. So this is the immediate response. So here you can see that the immediate response is occurring within seconds. Within the first 15 to 30 seconds, you can see all of the immediate responses are activated if there is a change in blood pressure. But the thing to remember about these immediate responses is that, of course, it happens very, very quickly, and it is quite effective very rapidly as well. And it has potent and profound effects on blood pressure. But the problem is that it is not going to be a persistent effect. You can see that all of them start falling roughly within 1 to 6 hours. You can see that all of these changes start declining. So this is not going to be something that is helpful in long-term control of blood pressure, but this is a hyperacute response to change in blood pressure, which happens at the neural level. So we do have additional responses beyond this as well, which generally comes in a little later, within a few minutes or maybe hours after a BP disturbance. So what are they? One, of course, is shifting the fluid into the intravascular volume. If the patient is having low blood pressure, then you pull everything into the intravascular volume and try and maintain the blood volume. If the patient is having high blood pressure, you shift the fluid out of the blood into the interstitial spaces in response to the increasing blood pressure. The second one, of course, is the renin-angiotensin-aldosterone system, which you're all familiar with, which is the commonest endocrine axis to be affected, to be involved in blood pressure control. So here, if the blood pressure is falling, the entire RAA system is activated. And if the blood pressure is on the higher side, then the body suppresses renin-angiotensin-aldosterone system. Along with this, there are also multiple vasodilator systems which get suppressed when BP decreases and stimulated if BP rises above normal. Today, we will not look in detail about the local vasodilator systems. We will stick to the hemodynamic and the humoral responses that we see. So here, this is a picture, the complete picture of what you saw earlier. So you saw the immediate response, which happened within seconds, the neural control. And then you can see a couple of hours later, if the blood pressure is not corrected with the help of these neural responses, then you have the entire gamut of renal body fluid response, which happens. And the thing to note about the renal body fluid response is that it is an infinite response. It does not come down to normal, or it does not come down to its pre-morbid values unless and until the blood pressure normalizes, or unless and until the correction has occurred. So this is something that can remain infinitely high. And that is why it is a key regulator of long-term control of blood pressure. And we will look at how it plays an important role in disorders in endocrine disorders causing hypertension. So when we look at renal body fluid mechanisms, a little bit more physiology about that. There are two aspects when you talk about renal and body fluid interactions. One is it works towards maintaining the blood pressure. The other one is it is closely involved in maintaining the salt and water homeostasis. And these two things are intimately connected. Very often, if the sodium intake is high, then what will happen? The kidney will excrete more sodium. So that natriuresis will also help in bringing the blood pressure down to normal or maintaining the blood pressure. So very often these two work hand in hand, they work together. However, if the body has to choose between the two, if the body has to decide, okay, at the expense of which one will it give more importance? So if that happens, then maintaining salt and water homeostasis becomes more important than maintaining blood pressure, because there are conditions where the body maintains normal sodium balance at the expense of having a higher blood pressure. Most of the time, you will not really require this if your kidneys, if your renal function is absolutely normal. But if your renal function is compromised a bit, then often the sodium and water homeostasis is maintained at the expense of having a higher than normal blood pressure. So there, the blood pressure is kind of reset to a different level. So we will look at that again in detail later. So when we talk about these renal body fluid mechanisms, there are a couple of things that you should keep in mind. One is what we call pressure natriuresis or pressure diuresis. So basically what this means is, if you have too much of sodium intake, then what will happen? Your kidneys have to excrete out that sodium. One of the mechanisms in increasing sodium excretion is to increase the intraglomerular pressure, or um, the afferent arteriolar pressure that is reaching the glomerulus should be high. So because of high pressure, that leads to higher excretion of sodium. So this is what is named as pressure natriuresis. And this is what I meant. Sometimes if the kidneys are unable to, kidney functions are slightly compromised, then pressure natriuresis is sometimes the main factor through which sodium excretion is achieved, because the rest of the kidney functions, which we're going to look at, may not be appropriately functioning. So what are all the renal mechanisms involved in maintaining both sodium and blood pressure control? So here I'm going to talk about the mechanisms which lead to hypertension. So if you have a situation in which the pre-glomerular resistance is high, which means, like the amount of the afferent arterial blood pressure is on the higher side. So there is reduced blood flow to the kidneys, and prior to reaching the glomeruli, the pressure is high. So that is one mechanism which will contribute to hypertension. We will look at each one of them. Another one is if there is reduced glomerular capillary filtration coefficient, reduced number of functional nephrons, and increased tubular reabsorption. So all of these are renal functions which should be appropriately present if, in order to maintain normal sodium homeostasis, your blood pressure also should remain in the normal range. Then you need all these mechanisms to be intact. So this is a graph which shows the pictures, the factors that I've just mentioned to you. So first we will look at the normal renal function. So here you can see that in a patient with normal renal function, so in the y-axis, you can see that the sodium intake is increased. This is the sodium intake that happens normally, and then it's doubled, tripled, increased 4 times, and increased 5 times. So in spite of increasing your sodium intake up to 5 times the normal, you can see that in a normal individual, the mean arterial blood pressure is remaining constant. The mean arterial blood pressure is not increasing; it is remaining exactly like this. That is because, so this suggests that this patient's blood pressure is not sensitive to salt or is insensitive to salt, because your kidney function is absolutely okay. You have other mechanisms of throwing out the excess sodium that you're taking in without increasing your blood pressure and keeping it in the normal range. So this is what happens in a normal person. Now we will look at what happens in the first situation that I told you, which is increased pre-glomerular resistance. So the classic example for this is a renal artery stenosis or constriction of renal arteries. So here what happens is, as the sodium is increased, again, you can see that the blood pressure does not worsen. The blood pressure remains the same. However, because of poor perfusion of the renal vessels, you can see that the blood pressure is already increased, and irrespective of the sodium intake, it is remaining at a higher level. So this is also salt insensitive hypertension. However, the sodium homeostasis is maintained only at the expense of maintaining a higher blood pressure. Now, if you look at endocrine causes, one of the endocrine diseases which has this mechanism of worsening of hypertension is a pheochromocytoma. Because what happens in pheochromocytoma is that there is excess catecholamines. So there, it is similar to activation of your sympathetic nervous system. So the renal sympathetic nervous activity is increased, and that will lead to afferent arteriolar vasoconstriction. So this is a functional constriction of the afferent renal arteriole, which then leads to increased blood pressure. Again, here, note that it is salt insensitive. In fact, these patients will be losing salt in their urine. So here in fears, typically because there is volume contraction, we actually ask them to increase their intake of salt in order to prevent the volume contraction. So this is the reason for that, because they're salt insensitive, and irrespective of the amount of salt you take, their blood pressure is going to be remaining at a higher level because of the pre-renal, pre-glomerular resistance offered to the kidney. Now, we will look at another mechanism, which is basically a reduced coefficient of glomerular filtration. So this is something that classically seen in glomerulonephritis, but with regards to endocrine, it will be seen in patients who have chronic diabetes and they end up having glomerular injury. So here again, you can see that this is a salt-sensitive hypertension, which means that as you increase the intake of your salt, you can see that the blood pressure is rising, right? So this is a patient who will benefit from salt restriction. And of course, this patient, this again, in diseases like chronic diabetes, where glomerular pathology is slowly happening over time, you can see worsening of the disease over time. The next one is, of course, loss of kidney mass. So here, not much of endocrine relevance as such, but this is if you have renal infarction and lost part of your kidney, or if there's a nephrectomy. So then this is a picture that you would get. This is now the most important endocrine aspect, because most of the endocrine or humoral control of blood pressure comes here. So here you have increased tubular reabsorption of sodium. So again, this is a salt-sensitive form of hypertension, because here you can see that as sodium level, as the sodium intake increases, you can see that there is a it's almost linear. There is an increase in blood pressure. So this is typically what happens in all your hormone-mediated hypertension, whether it's mineralocorticoid or apparent mineralocorticoid excess. You will see that as the sodium intake increases, the hypertension worsens. And this occurs because from the tubules, there is increased reabsorption of sodium, which leads to increased intravascular volume. And this elevated intravascular volume is needed to be maintained for you to undergo pressure natriuresis and maintain sodium homeostasis. Otherwise, your sodium is going to rise. So because the tubular reabsorption is increased, this is a kidney dysfunction which does not allow you to maintain a normal blood pressure. So sodium homeostasis is maintained at a higher blood pressure level. I hope that was relatively clear. So if you look at common factors, which I've already discussed in the picture, common factors with regards to endocrine hypertension, you will see that if you look at the various causes leading to hypertension because of whatever secondary disease you take, you will see that eventually it will boil down to either increased sympathetic nervous system activity or activation of your renin, angiotensin, aldosterone system. And these two things will lead to vasoconstriction. That's one factor which increases your total peripheral vascular resistance. And sometimes they will also increase the cardiac output. And these are the two factors which will push the blood pressure up, if you remember the formula that we started off with. So this is a photograph which shows you how sympathetic nervous system is important in blood pressure control. Here you can see that patients who were refractory to therapy underwent radiofrequency ablation of the renal sympathetic nerves. And you can see for the next 1.5 years, their blood pressure remained lesser than how it was before, and it persistently remained low for the next 1.5 years. So this is just to show that there is a significant contribution of activated sympathetic nervous system activity in patients who are having hypertension. This is another picture which is trying to explain. Now we have moved on to the renin-angiotensin system. So here, if you look at, again, if I could just use the pointer. So this is the green line is the normal blood pressure, right? So here you have a patient. This is your sodium intake like we saw earlier. This is one, and this is increasing your sodium intake by doubling, tripling, etc. And this is your mean arterial pressure. These little values that you see on the side are your angiotensin levels in the blood. So here you can see in a normal person, the angiotensin level was 6. But as the sodium intake increased, the angiotensin becomes suppressed. So what happens as you take more and more sodium? So if you take more and more sodium, your distal delivery of sodium in it increases. So what will happen? There will be the macula densa will sense more sodium. It will send signals. So what will happen is your renin, angiotensin, aldosterone system will get suppressed. So you don't want to retain any of the sodium. You want to throw it out. So it will suppress the angiotensin levels. So if you keep on increasing your sodium intake, here you can see that the angiotensin level has become 0. So here is a patient who had adequate angiotensin levels when the sodium intake was very less. And this is what is maintaining his normal sodium in the blood when the intake of sodium is close to 0. But as the sodium became normal, it became less. And when the sodium increased, the angiotensin levels completely suppressed. So this is how the patient will maintain normal blood pressure and normal sodium levels throughout. Now here is a patient, with the red line is showing you when the patient is put on angiotensin blockade. So this patient is on ACE inhibitors, which means angiotensin cannot be synthesized. So irrespective of the sodium intake, you can see that the angiotensin is remaining 0, 0, and 0. So when the sodium intake was very less, that's fine. The blood pressure is also less. You're unable to increase the angiotensin significantly here to bring the blood pressure to a better level. So the blood pressure is remaining on the slightly on the lower side. Now, as your sodium intake normalized, again, you didn't have to make much of an angiotensin here, but the blood pressure is maintained within the normal range. But you can see that once the patient's sodium intake has increased, and here now the patient cannot suppress any further because it is already completely suppressed right from here. So the only way to maintain sodium homeostasis is to increase the blood pressure and throw out sodium using the pressure natriuresis that I spoke about earlier, because your RAS is not getting suppressed in order to prevent to facilitate sodium excretion. So this is what will happen. So you need here a higher pressure, a higher glomerular pressure to facilitate pressure natriuresis, and this is what will happen in a patient who is on angiotensin blockade. Now on this side, you will see the patient is having high angiotensin 2 levels. So this is maintained by giving exogenous infusion from outside, because once the sodium increases in any normal person, what will happen is angiotensin will become 0. So in order to study the effects of elevated angiotensin or non-suppressible angiotensin in the face of rising sodium, they have given a small dose of angiotensin infusion. So here you can see at a very low sodium level, the angiotensin is elevated, blood pressure is maintained. But here, even in normal sodium intake, because angiotensin it's unable to suppress, it's not suppressed at all, it's remaining the same. So how do you maintain sodium homeostasis? You've increased your blood pressure. You're further increasing your salt intake, the blood pressure is keeping on increasing because you're unable to suppress the angiotensin. So this is typically what happens in someone who is salt sensitive. So in a patient who is having elevated or activated RAS, either angiotensin or aldosterone, even little bit of salt intake will be compromised using higher and higher blood pressure. So these are salt sensitive patients with hypertension. Even little bit of salt intake in the presence of either elevated aldosterone or elevated angiotensin will lead to further worsening of blood pressure. So this is again how angiotensin acts. You can see the mechanism. It is converted to angiotensin 2, which acts on the AT1 receptor, which is what basically causes most of the ill effects related to aldosterone, the RAS system, which is vasoconstriction, sodium retention, increased blood pressure, inflammation, etc. Whereas if you look at the other metabolites of angiotensinogen, you can see that they actually cause vasodilatation. So this must be could be a area of therapeutic interest in the future. So again, this is just a picture from Williams showing you what happens when the circulating blood volume, if it falls and the renal perfusion pressure is reduced, then what will happen? You will have the JG cells producing renin, and that renin will give rise to angiotensin, which will cause aldosterone, and the aldosterone will act by worsening potassium excretion, but holding on to sodium and maintaining the blood volume. Similarly, other permissive factors are catecholamines, potassium, and macula densa feedback, which also will give signals to the JG apparatus to either increase or decrease the renin release based on the blood pressure. This is just a picture to show you where exactly all these are located. So this is your afferent arteriole, and here is your juxtaglomerular cells. So as it gets filtered and comes here from the efferent arteriole, the macula densa is able to sense the sodium delivery here, and then it will send signals to the afferent arterioles and the juxtaglomerular apparatus to secrete or suppress renin. So once aldosterone is secreted, the renin will produce angiotensin 2, and that will produce aldosterone. So once aldosterone is increased, how does that act? It will act it will attach itself to the mineralocorticoid receptor, and it will act on predominantly this particular receptor, a transporter called the ENaC here, which is a sodium channel, epithelial sodium channel, and it will open it up and cause sodium reabsorption. And this is the sodium potassium ATPase on the other side. So this is how sodium reabsorption occurs via action of aldosterone in the distal part of the nephron. So if we want to understand hormonal regulation of blood pressure, just like diabetes, the best place to look at is to look at monogenic causes of hypertension, because that will give us a very clear clue as to what are all the main pathophysiologies associated with blood pressure control. So this, the first one is the familial hyperaldosteronism 1, which all of you are familiar with, which is also called glucocorticoid remediable aldosteronism. And here the problem is a genetic defect, where there is a chimeric gene where the 11 beta hydroxylase is linked with the aldosterone synthase. So you have aldosterone synthesis or secretion, which comes under control of ACTH. So this is you generally seen in the second or third decade. It's autosomal dominant. Again, how does it act? Basically, it acts by producing too much of aldosteronism. So it is something similar to your Korn syndrome, except it's not an adenoma. It is a genetic disease leading to increased aldosterone secretion. Similarly, you have a whole bunch of genetic causes now, which causes familial hyperaldosteronism. This is an old table that I just took for reference, but please refer to your Williams. You will see that there are 4 variants described as of now, and the different genetic mutations which cause FHA1, 2, 3, and 4 will be mentioned there. Then another one is what is called the apparent mineralocorticoid excess. So here you have a bunch of steroidogenesis. If you look at the steroidogenesis pathway, you will see a lot of intermediaries there, namely DOC, which can act on the mineralocorticoid receptor and lead to the same picture as elevated or primary aldosteronism, except that your aldosterone levels also will not be elevated, it will be low, because the action is by one of the predecessors or precursors of aldosterone. So even cortisol, if it's present in very high amounts, will cause the same thing, will cause the same autosomal apparent mineralocorticoid excess. So these are enzyme deficiencies which lead to accumulation of precursors which have mineralocorticoid activity. So that is another mechanism of monogenic hypertension. So lastly, you have another 2 syndromes. Little syndrome is nothing but the last picture I showed you, an epithelial sodium channel, or the ENaC. So if you have a mutation of the ENaC, which is an activating mutation, sodium will keep on getting reabsorbed. That is what is referred to as Little syndrome. And Gordon syndrome is another transporter which is present in the renal tubule again, which is a sodium chloride transporter. So there also you will have reabsorption of sodium because of activation of this this particular transporter. And this is the site of action for thiazide diuretics, which is why thiazide diuretics will be a good therapeutic option for this. So if you look at all causes of monogenic hypertension that are available to us, you will see that it comes down or boils down to the renal tubule and the hormones which act on it, and the receptors and the transporters that are involved in it. So essentially, your blood pressure control goes down to the hormones which are secreted and act on various renal sites. So all monogenic causes can be traced to renal and sodium homeostasis pathways. Now, quickly, before we finish, I'm almost coming to the end of my talk. Just for the endocrine benefits, we will just look at some common endocrine diseases and whether our theory that it will all boil down to the entire RAS, SNS, and effects on the renal system or not. So if you look at obesity, again, what is important to remember here is it's visceral obesity that is important and not subcutaneous obesity. So if there is visceral obesity, one is there is increased leptin, and leptin is known to activate sympathetic nervous system. Also, leptin can also activate RAS. Also, visceral obesity itself can activate RAS. Also, if you have renal compression from perinephric fat and renal hilum fat and the renal hilum compressing on its vessels, all of these can cause RAS activation as well. So all of them will eventually lead to sodium reabsorption. So you can see that visceral obesity is boiling down to increase RAS and increase SNS, sympathetic nervous system activity. Of course, you have diabetes, dyslipidemia, arterial hypertension, which comes as part and parcel with obesity most of the time, and all of them will also lead to worsening of renal injury. Now, if you look at acromegaly, again, here you can see that Acro is known to have direct action on the RAS. It can activate RAS. It also has some action on direct aldosterone secretion and direct action on the ENaC as well. So in GH and IGF-1 excess has multiple ways of activating the entire renin-angiotensin aldosterone system. There is also hyperinsulinemia and insulin resistance. Again, insulin resistance we know can lead to endothelial dysfunction and vascular smooth muscle dysfunction, which worsens the vascular resistance. And hyperinsulinemia can worsen SNS activity and also directly cause sodium and water retention. So again, it will come down to some increased sympathetic activity and activation of the various RAS components. Here, in addition, you also have factors like endothelial dysfunction and insulin resistance, which has worsened the vascular resistance as well. This is pheochromocytoma. So here you can see that in a patient with pheochromocytoma, there is secretion of catecholamines, which acts on the alpha receptors. And this will activate the GTP. It will activate PLC that will cleave this protein. It will release IP3, which will cause release of calcium from this channel, the ligand-gated calcium channel. And this release of calcium from the ER into the cytosol will cause a constriction of the vessel by vascular smooth muscle contraction. So here you can see that it's predominantly mediated by release of intracellular calcium, which leads to vascular smooth muscle contraction. So here, but this entire catecholamine release into the blood will, like I told you earlier, will also activate sympathetic nervous system, particularly the renal sympathetic nervous system, and will lead on to increased preglomerular resistance and hence activation of RAS and hypertension, sodium retention. So here it's also showing you what are the good drugs that you can use. So either you block the synthesis of norepinephrine, or you block the action of the released norepinephrine onto the receptor, or because the end point is by release from the calcium channel, you can use a calcium channel blocker also effectively to control the blood pressure in this patient. Now, when you look at Cushing's, again, like I mentioned earlier, one of the features of cortisol is that it can act exactly like a mineralocorticoid, like aldosterone, and cause all the effects of aldosterone similar to it. And apart from that, again, it acts on the on the vessels. It has reduction of vasodilators and increases all the vasoconstrictors and increases the response to vasoconstrictors as well. So again, just like in pheo, you can use CCBs because it is causing vasoconstriction of renal vasculature and activating the RAS system. It makes sense to use ACE inhibitor ARB as well. And of course, because direct action is present in the mineralocorticoid receptor, MRA is a good drug of choice in controlling patients' blood pressure with Cushing's as well. So that brings me to the end of this talk. Many endocrine disorders present with hypertension. And it's important to know that maintenance of blood pressure is closely linked with sodium and water homeostasis. And eventually, it always happens due to alteration in the renal body fluid mechanisms. And if we understand the pathophysiology of what is leading to hypertension in each disease, it will help us to choose the appropriate therapeutic agent. Thank you.